Welcome to Value-Based Care Insights. I am your host, Daniel Marino. Well, we have a special episode today where we are going to cover what we see as the three most popular episodes of this past year that cover a lot of the major topics I think that we've all been struggling with. And we've identified these episodes really coming from you, our listeners, based on the number of impressions, the feedback that we received directly through to any one of us, comments and so forth, and just some suggestions in terms of additional topics you'd like to talk about. Our first episode that I'd like to share addresses a topic that I think we've all worked through. It's kind of been top of mind for the industry, and that's really around Medicare Advantage. For some organizations, Medicare Advantage has done real well. Other organizations, it's been a challenge. Our first episode I'd like to share comes from Sarah Hartley. She was a guest last spring and has done a great job of working with her Medicare Advantage payers as well as her providers, creating a real strong collaboration that has driven a lot of success for her organization. Let's listen to parts of that episode.
Sarah, as I mentioned, it's no secret. Many organizations have really struggled with Medicare Advantage. I think from a couple of perspectives, many of them have seen a lot of the administrative challenges associated with the level of reimbursement for Medicare or Medicare Advantage. There's challenges with getting pre-certifications, there's increased denials, there's administrative costs that have been associated with managing the relationship. What are some of the challenges that you've experienced or that you've seen as you've worked through a lot of your MA contracts and your MA relationships with your payers?
I would say probably our biggest challenge is taking on that administrative burden and getting the physician buy-in in that, because there is a lot of administrative burden back from MA plans in terms of data, the amount of data that we receive, the requirements to meet all of the measures. And so the challenge is, how do we make it easy enough for our physicians to address it with their patients and meet the needs of our payers as well?
Yeah, I can see that. And the reimbursement, when you look at the economics, the reimbursement is at Medicare rates, right? In some cases, may even be below Medicare rates for associated with the MA contracts. But the key to it is, as the performance of the plan improves, as the star ratings of the plans improve, then there's incentives that are associated with that, right? So if you're looking at a 4.5 star rated plan, that incentive on top of the Medicare reimbursement is higher than a 3.5. But it does not take the place, I think, of the administrative services, right, that are required. Are you seeing, when you talk to some of your colleagues, are you seeing an increase in a lot of, say, denials related to some of these pre-certs and other activities that you normally wouldn't get if you were in straight Medicare?
Yes, we see a lot of denials and pre-certs, the increased scrutiny with our DME providers, increased scrutiny with the annual wellness visits. There are quite a bit of denials coming through that we just don't know how to manage yet, yeah, especially in the new space.
Well, absolutely. Absolutely. And I think that's what a lot of folks are looking at. The other area that you touched on a little bit, it's the performance outcomes. So the other challenge that we have with Medicare Advantage is, not only are we faced with potentially higher denials and reduced reimbursement, but there's also performance outcomes that we have to hit as an organization. How have you been able to overcome that challenge?
I think the key is to have a holistic approach. We have to get out of working in silos in healthcare. The goal is to keep our patients out of the hospital, and we have to work with our hospital providers and our outpatient providers to look at the patient as a whole and treat them as a whole. And so getting that data from our payers can really help us manage that. So getting the subject matter experts at the table that can speak to each piece of that movement for the patient through the system.
Has getting the data from the payers, I know you have your own data, right? And you're looking at your billing data, you're looking at your quality data. I'm sure you're pretty sophisticated, so you're looking at a lot of the reports to identify how you can kind of close the gaps and so forth. but the data from the payer is really important. Have you been able to create that alignment around sharing of that data with your payers?
Not yet. We are building a platform to do so. The challenge is that our internal data just looks at our claims.
Right.
You know, a patient can go anywhere. And so when you look at them as a whole patient, their RAF score, their quality measures under that contract, they can go anywhere and the patient needs to be managed appropriately. So as we align and we can see the data align, if we get it into one platform, then we can see the pictures, the patient's whole story, regardless of where they go. So ingesting that data is the path that we're on right now to paint that picture of the whole story.
Yeah, so it's really the claims data, right? Because as you said, the patient can go anywhere. And you have your billing data, so you know what's occurring within your organization, but you don't necessarily know what if they, you're in Chicago, so you may have a lot of folks that go down to Florida, right? The snowbirds or to Arizona.
Correct.
So if you're responsible for them, you need to get that claims data and really begin to understand what's occurring as they do get care elsewhere.
Yeah, absolutely.
How about the vastness of the data? I mean, one of my clients I was talking to, we were helping with some modeling of a Medicare Advantage contract, and the amount of data that they had both internally in the organization, and then they did get sample data from the payer. Pulling that together was enormous. Is the vastness of the data typically an issue?
It's a major issue. Especially if you think about all of the plans that you contract with. Everybody has a different way of looking at the data. They have different terms for their data. They have different processes, different platforms. And then when you get into managing all of the patients or all of the beneficiaries in those plans, it can be enormous. And it's overwhelming. So the biggest question, the most important question to me is, what are we going to do with it? Is it actionable data?
A second topic that we've all been working through is really balancing fee-for-service versus the advancement of value-based care. And we have seen value-based care increase in terms of the number of contracts, in terms of the number of revenue, attributed revenue to value-based contracts, and so forth. One of the areas that we've heard from all of you, and as we've worked with our clients around the country, an important topic is around the infrastructure, and in particular, care management. Well, late last spring, early summer, I invited Dr. Riya, Pulicharam, and Kevin Zhao on the program to share their solutions around care management. And what struck me about this episode was how Dr. Riya really highlighted the need to have performance reports of the care managers, but making sure that it's integrated well with the clinical pathways that help support physicians proactively, as well as then supporting the quality of care delivering to patients. Let's listen to a little bit of that episode.
So this concept of prospective care management is really gaining a lot of attention, especially as we start to work with organizations, or as we see organizations taking on more full risk, global risk contracts. Well, I'm excited today to have two extremely knowledgeable guests talk about this concept of prospective care management. Our first guest is Dr. Riya Pulicharam. She's a national expert in population health, has over 25 years of experience as a physician researcher and a national medical director. She's done a lot of research around outcomes, cost of care models, incorporating that into the right elements to drive efficient population health. My second guest as well is Kevin Zhao. He's co-founder and CEO of Carrot Health. Carrot Health is a platform that is really looking at a lot of different data and artificial intelligence to drive new care models and new care management. Dr. Riya, Kevin, welcome to the program.
Thank you, Dan.
Thank you for having us. Appreciate it.
So Dr. Riya, maybe we could start with you. Given your experience, and you certainly have had a lot over your career, what do you see as some of the key challenges in the traditional care management structure that we often see today?
Yes, so there are lots of challenges in the care management processes and structure today. It hasn't, it was still the same when I first started 25 years ago. It hasn't changed much over the years. One of the main challenges, Dan, is it's more metrics driven, not outcomes driven.
Yes.
When I say metrics, it's important. Metrics is important because that's how they're measured, right? The care managers. So I'm not saying it should not be metrics driven, but it has to be equally and more outcomes driven. It also depends on the organization, right? Some organizations are more metrics driven, and some organizations are shooting for outcomes driven as well. But where do they start? Yeah.
Let me dive into that for a second, because you bring up a really interesting point. So when we think about diabetes, and let's say you have a patient who's a high-risk diabetic, and we have, let's say, a metric to measure their A1C level, and high risk, let's say we consider it, they have a 7.5, for instance. So I think what you're saying is oftentimes care management is really building the interventions around that metrics of 7.5, instead of thinking about what are the care management solutions that would almost drive the outcomes of reducing the high risk diabetic to maybe a 6.9, if you will.
Yes, but I was also focusing more on the metrics of how it's traditionally care management processes are set up, like high touch. How many calls did you make?
Right.
So reducing hemoglobin A1C would be an outcome.
Sure.
Right? So if you made your calls as a care manager, you've met your target. Who are the patients that you need to call? So they're focusing on that. And that's how they staff. Right.
So
but
it's really the outcome of
yes.
of what the care managers are doing that needs to be tracked.
Yeah. What is the result? Right. So of course, when I'm the manager leading a team of care managers, I do want to set the metrics because I can measure how many calls they had to make. But at the end of the day, it is also the outcomes of their calls.
Well, it's the efficiency. Absolutely. So Kevin, let me turn to you for a second. Historically, it's been very difficult to measure let's say the productivity of care managers. And I think especially to track it, how Dr. Riya is describing, thinking about not only what they're doing, but what are they producing out of the work that they are creating within the care management platform. What's some of the data that you begin to look at to drive that level of outcome?
Yeah, I think there are a lot of existing point solutions today that track, I guess, the metrics that Dr. Riya is talking about. So how many calls you made, how many minutes you spent, et cetera. And these platforms tend to do well in more of a fee-for-service type of environment, where the goal is to rack up, generally as many transactions as possible and bill insurance. Within the value-based care space, which is where I focus on, these types of transactional tracking methods work less well. And what we have to do then is figure out ways to translate some of these transactional tracking methods into more of these outcomes based assessments. One way to do this, for example, is, let's say if you have an entire population of patients, you want to be able to identify one for each cohort of patients, what's their likelihood of receptiveness to various interventions or outreach. If you reach out to a patient, for example, how likely is that patient to actually follow through with what you're asking the patient to do? The second is, for example, the amount of effort that each intervention, outreach, or task is going to take. So for example, if you want a patient to, let's say, complete a colonoscopy, for example, or get a test done, how much effort is it going to take to reach out to patients, set up those appointments, and follow up with them? And then the last one is the actual outcomes ROI of that task or this intervention effort. So if a patient does go through with their colonoscopy, mammogram, or et cetera, what's that ROI for you as a value-based organization? And I think measuring the overall effectiveness, productivity is a factor that it's a formula that you have to multiply all these together. In terms of knowing that your team, has very limited resources. Let's say out of 1,000 tasks, like outstanding gaps, you'll only be able to handle, let's say, 100, per week or 100 per month or whatever the bandwidth is, how do you make sure that the highest ROI, overall tasks are done, first before trickling
Oh,
down to the
absolutely.
rest?
And
Yeah,
that's a great point, because I'll tell you, many CFOs, they understand what the costs are of investing in care management. What is difficult to track is the ROI. And
that's right.
And I think if you're going to start with that, Dr. Riya, it seems to me as Kevin was talking about it and describing, those three elements, the care pathway, the care protocol, the clinical pathway care protocols that are put in place are critical, right? I mean, I think that's the source of truth.
Yes. So care pathways are, very important as they assist us in clinical decision making, right? And they also provide a recommended course of action. As these patients, unfortunately, especially the most, expensive patients, right? The high risk patients, they don't come with just one comorbid condition. They come with multiple chronic conditions. And when you have multiple chronic conditions, you really need to balance. And you also need to, coordinate this care pathway with social determinant issues. So if they're tied together, then it becomes a really good protocol. And if that is not automated, then it's very difficult for any care manager, if their data resides, in a siloed manner in Excel spreadsheets, and it's not all tied in appropriately, then what happens is there are these blind spots. You're not aware of some things, you forget some things, and at the end of the day, it just becomes more complex and more confusing, and then you don't get to the right data. So care pathways are only as good as how you position them and how you automate them and how accessible it is for you on every patient.
A third topic of interest this past year was the advancement of clinical service lines, everything from cardiovascular services to surgical services to even some of the medical specialties. A lot of organizations were considering their strategy to advance their service lines. One area that we continue to see as a challenge is supporting surgical services and the OR activities of hospital, and in particular, overcoming the anesthesia shortages that we see around the country. Last summer, I invited Dr. Dave Lebec and my colleague Tim Hanners to the program. We spent some time talking about those challenges of anesthesia, as well as some solutions that providers should consider as they start to enhance their surgical services and create more profitability for their organization. Let's listen to a little bit of that episode.
Some of the real challenges that healthcare providers are struggling with as they're thinking about maybe either realigning some anesthesia services or just responding to some of the surgical needs that they have within their community.
Yeah, so you hit it, the hospital administrators, CEOs, and in particular CFOs are really struggling right now. They're very frustrated because you're right, traditionally the OR has been a real driver for financial performance for everything. And there's some things that are a bit out of their control because the payers, of course, the financial margins of the OR shrank and are shrinking greatly. And then there's some other factors where a lot of their OR business has gone to ASCs.
Sure.
And that's of course been orthopedic, but a lot of other things are moving to the ASC procedures and surgeries.
Right. So we're seeing that shift in site of service. So Dave, I can't help but think that this puts probably the anesthesiologist in a real difficult position, right? I mean, to one extent, it's always great to be needed, and yet, and I'm sure they can get pretty much roles anywhere, but they have to be, I would think, certainly professionally challenged on really meeting the needs of the provider organization and even their surgical counterparts.
Yeah, so first of all, thanks, Dan, for inviting me for this great topic today. And yes, you're correct. In the post-pandemic world, we've seen a shift in how providers both perform their duties, anesthesiologists as well as CRNAs, roles expanding, roles changing. we've also seen a shift in the employment models, which we're going to talk about today as well. And the primary kind of stressor we see is that anesthesiologists still want to take care of their patients, work with their surgical colleagues, yet sometimes they do feel they're caught in the middle of a battle between, say, a national service provider company as well as the hospital. And they feel that sometimes this creates a barrier to them providing the care they need for the patients that they see each day. And importantly, I think we mentioned already by Tim, the expansion into this ambulatory surgery centers as well. Prior to the pandemic, surgery centers were often taking care of lower acuity patients with a small, diverse, not so diverse set of surgical procedures. But now we're seeing the rapid expansion of surgery centers, some with 24 to 48-hour stays, doing more complex procedures that require different skill sets.
Sure.
So we're seeing these surgery centers expanding with a higher demand for higher sets of skill sets, and yet a national shortage of anesthesia providers, both CRNAs as well as anesthesiologists. So as you can see, there is a production pressure as well as a service pressure that's placed on all the providers.
But you made one interesting comment, Dave, that I want to dive into a little bit. So are you starting to see more of a trend towards employment? And if so, why is that the case? Is it because of those economic pressures, or do hospitals feel like they could, I don't know, create a better relationship with their anesthesiologists and align that with the surgical providers? What's the big driver of this?
Great question, Dan. And what we're seeing is a shift of more towards the employed model by the hospitals. Traditionally, this has not been a very appealing model to anesthesiologists or CRNAs in the past prior to the pandemic, as hospitals often would only be able to provide certain compensation packages that were very stringent, very strict, that were not very dynamic, reflective of the types of cases each provider was doing, as well as the demands placed on those providers. Post-pandemic, when we saw a lot of the private anesthesia practices become stressed financially as well as operationally, being unable to support financially their own practice, as well as recruit providers with a national shortage, we saw those private groups go under.
Mm-hmm.
And that created a market for both the PRN or the per diem providers, independent contractors, which we're seeing a large spread of that throughout the Northeast especially, as well as also having the providers move towards the hospital models. And the hospital models have become more transparent, have been able to reflect incentive-based compensation, which is a key for anesthesia employment going forward. And the hospitals have been able to adapt their models to attract these providers, notwithstanding the new legislation out there for non-competes, but also allow the anesthesia providers, if they do have a non-compete, it's now not geographically widespread as with a national company, but more focused on just a hospital. In most cases, the hospitals don't even have a non-compete or a non-solicitation clause in their contracts. So it allows the providers to maintain their place of practice where their families have grown up with the hospitals and surgeons they have worked with throughout their careers, with less stress, more transparency, and more importantly, compensation models are aligned with what they want to do with a work-life balance, as well as being rewarded for the work they're doing clinically, as well as engagement with the hospitals.
Well, and I'm sure it allows the hospitals to have more influence as to what's occurring with their providers. And especially if you have all of these dynamics around shortage and recruitment and so forth, you know, the hospitals may not be able to solve the problem, but at least they can influence it. Tim, when you're having conversations with your CFO counterparts or the administrative counterparts, what are they seeing as some of their economic opportunities related to employment?
You know, well, first of all, they're also sort of struggling with that, right? Because to Dave's point, they haven't done this with anesthesia. The staffing models are different, and they're really scratching their heads on what is the right way to do this. What's the right structure to have for my staffing models in anesthesia? I don't know how many MDs I need compared to CRNAs or even in some states AAs. And so they're really trying to figure out, where is my financial opportunity? I know I can't sustain what we're doing. These subsidies continue to increase, but I don't know how to restructure it and what are my options for employment? Dave can speak to some various different models. It's not always with anesthesia, just employ or not to employ or to contract, but there's a lot of variables there of they can employ CRNAs, but maybe they aren't by state regulation allowed to employ the MDs.
3 great episodes. I hope you enjoyed that as much as I did. I want to thank all of you, our listeners, for tuning in, and also a special thanks to all of our guests. If down the road you have any questions or want additional information or have an idea around future topics or just want to connect, please reach out to me at dmarino@luminahp.com. You could also find me on LinkedIn by searching Daniel J. Marino. Looking forward to many great episodes in 2025. And again, as always, looking forward to your comments as well. I want to thank everyone for listening and tuning in. Until our next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organizational performance? Visit us at luminahp.com to learn more about our consulting services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. For more information about value-based care insights, visit the programs page on healthcareradionow.com or luminahp.com. Join the conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next value-based care insight, stay well.